Good evening. This discussion will cover the remaining portion of your high-risk pregnancy, Chapter 21, Complications that Arise Throughout the Pregnancy. I'd like to pick up with where I believe bridge us from where we left off in class, and we left off talking about hypertension in pregnancy. And in class, we did address pathophysiology being what is believed to be vasospasm of the smaller vessels in the body as a response to pregnancy. And what you'll see is that the assessment and interventions for hypertension in pregnancy or gestational hypertension are mainly directed at what we're seeing clinically in the patient and what margin of the disease they have. If it's simply gestational hypertension, are they moving to preeclampsia or a severe preeclampsia or even eclampsia with help or in worst case DIC. So you'll find that most of the material presented here is very dependent upon your assessment findings. Sorry about that, guys. I'm going backwards, not forwards, am I? So my computer is locked. Okay, so the grid that we looked at in class showed the progression from gestational hypertension to mild preeclampsia, that's now including the proteinuria, 1 to 2 plus, and then the severe preeclampsia. So we know that gestational hypertension is when we see hypertension that develops after the 20th week of pregnancy. And what that definitive is that the woman would have a blood pressure of 140/90 on 2 separate occasions within 1 week, minimally 4 hours apart. And as the disease emerges, she could enter into mild preeclampsia with the proteinuria and then progress even beyond that to severe preeclampsia, where we start to see those significantly elevated blood pressures, again, happening twice, 6 hours apart, and she's been on maintained bed rest. You can see that the proteinuria now is 3 plus. We start to see a decrease in her urine, oliguria, and her serum creatinine will begin to rise. She will be exhibiting those cerebral changes, the headache, the visual changes, hyperreflexia, the clonus, which we talked about in class, dorsiflexion. Overall edema begins, pitting edema will certainly present itself. And then she may have those hepatic changes in her lab. She may have epigastric pain, right upper quadrant, and then we start to see the thrombocytopenia. So the difference between the severe preeclampsia and the eclampsia, as you know, is the manifestation of seizure activity. And this is associated with those neurological changes and the increased edema of the brain. You may see level of conscious changes, you may see mental status changes, and the thing that we want to keep an eye out for this client is that there is a high correlation that she could develop what we call HELP, and that's that hemolysis, elevated liver enzymes, and low platelets, and that could ultimately lead to DIC, which we did cover in class. So it's a sequelae, it's a progressive sequelae, and these are the things that we're assessing throughout the progression, just to pick it up. Now, excuse me, we do want to stop here because I want to offer you an opportunity to sort of clarify some clarifying questions. So we know that there is a difference between primary or essential, it can be worded either way, hypertension and gestational hypertension. So think to yourself, what is the difference between primary or essential hypertension and gestational hypertension? That difference, I'm hoping that you are sort of clarifying in your head, is the woman who has been diagnosed with hypertension before the 20th week of pregnancy, has had this diagnosis perhaps even before her pregnancy. Well, she has primary hypertension. The woman who develops hypertension after the 20th week, she has gestational hypertension. What is the difference between preeclampsia and eclampsia? And really, there's only one thing. We see all those significant conditions that we see in severe preeclampsia. Once she's seizing, we call her eclamptic. And what is the difference between gestational hypertension and gestational hypertension with help? And gestational hypertension can be just that. Many women have just gestational hypertension throughout their pregnancy, and that's it. And they may not progress to preeclampsia. Some women can have gestational hypertension, not have the eclamptic piece, but yet still develop HELLP because they have some liver congestion and liver changes. So just trying to clarify to you, like, to what things can be going on. So now that you kind of understand the pathophysiology of gestational hypertension and eclampsia and the progression of the disease and the manifestation, we need to look at those who are at high risk for developing gestational hypertension. And some of the things that come to mind are maternal age can be a factor, the very young or the very old. And very old, 38 is not very old, guys. But in pregnancy, we know that's advanced maternal age. So that can be a consideration. First pregnancy absolutely is a risk factor. We see gestational hypertension more often than not in the first pregnancy. Morbid obesity, that's a BMI, anything 30 or above. Multiples, so if she's carrying twins, triplets, or beyond. Renal disease, because she has poor renal clearance, perhaps. If she already has primary or essential hypertension, she is at high risk for developing gestational hypertension. So this is where you just go, what? Well, she already has hypertension. She's now pregnant, experiences this vasospasm, and it is possible that then she enters into the sequelae of preeclampsia and eclampsia. She's at higher risk if she's already got hypertension. Other members of her family, especially sisters or her mother, who may have had preeclampsia, diabetes, or if she had a previous pregnancy with hypertension, we're going to look at that as well. Manifestations of gestational hypertension, we've already kind of talked about these in class and in this discussion, but the primary manifestation is that elevated blood pressure, so the hypertension. The proteinuria is what we're watching to delineate whether she's moving into preeclampsia and how severe that might be. The central nervous system irritability, and again, the things we're going to see that tell us is that she's going to have changes in her vision, perhaps seeing spots, photophobia, she can't look at the light, hazy vision, blurred vision. She might have changes in her mental status, her reflexes or deep tendon reflexes, hyperreflexic. She might have changes in her pupil reaction. She could have clonus when we dorsiflex the foot. So there's lots of things that can be to indicate CNS irritability. Liver changes. So we start to see lab values change. We might see jaundice because of the hemolysis of the red blood cells. We could have that epigastric pain, pressure, sometimes they'll refer to that as. We see those renal changes, so we start to see oliguria, concentrated urine, and then ultimately those fluid shifts. So she starts to become edematous, it's pitting, it becomes generalized, right up to through the face, and we see those real sharp weight gains when she's up over 2 pounds in a day or two, right? So what are we going to do for nursing care? How are we going to care for this client? Obviously, we're monitoring all those manifestations in her blood pressure, and we may have to consider what meds would be used. And magnesium sulfate is a med that is not curative. It does not cure gestational hypertension or eclampsia, but it does change the seizure threshold. So when women have lots of those signs that she's moving to severe preeclampsia, we know that she's at risk of seizing. Magnesium sulfate will reduce the likelihood that she's going to seize. Of course, with the administration of magnesium sulfate, we have to be mindful that it has 2 significant side effects, and that is respiratory depression, because it is a smooth muscle relaxer, and the CNS depression as well. So we're always going to monitor those neurological pieces. We also might manage this woman with antihypertensive, things like calcium channel blockers or beta blockers. Pay close attention to nutrition. She may be fluid restricted depending on what her fluid balance looks like. And certainly we're going to monitor her salt intake. Her daily weight will be done to monitor her for her fluid volume shifts, strict I&Os. We've already talked about those neuro assessments, the reflexes and the clonus. We need to look at her baby. We need to perform ultrasounds to check for growth. We need to do NSTs, perhaps even biophysical profiles to check on fetal well-being. And we're going to teach this mom how to do kick counts. Is she monitoring the movement of her baby? Is her baby okay? It is likely that she's going to be on bed rest if she has gestational hypertension. Left lateral would be the preferred position. And we may, if she moves into severe preeclampsia, initiate seizure precautions. So paying close attention to a quiet room, decreased stimulation, turning the lights out. Perhaps we may need to get an order for the 4 bed rails to be up, and we would pad them. And we would place her close to the nurse's station so that we know we can observe her closely. We minimize traffic and visitors and things like that. We also want to keep a close eye on her labs, especially those liver function tests, to monitor that whether she's entering HELP. And for DIC, the things we look for is that spontaneous bleeding, like bleeding from the gums, petechiae, things that indicate that she's not clotting well. So we've talked a little bit about MAG in class with the preterm laborer. We can use it again with the gestational hypertensive client, and that's really about minimizing risk of seizure. So smooth muscle, central nervous system. We've talked about that this is a high-risk med, so it has to be double-checked by 2 nurses when it's hung. We need to pay close attention to her respiratory and neuro checks, usually very often, every 2 to 4 hours. We're monitoring the baby's fetal heart rate. We're going to be using an indwelling catheter. It should be on a pump. We should not be running any fluids more than 125 mLs per hour. And we're going to assess for those signs of toxicity, which we usually see when she gets up over 8 milligrams for a lab value. And signs of toxicity are she loses her deep tendon reflexes, her urine output drops off significantly, less than 30 an hour. Her respiratory rate might drop to less than 12. She may have changes in her mental status or level of consciousness, and she could develop a cardiac dysrhythmia. So some protocols will ask to put the woman on telemetry. The antidote for magnesium sulfate, calcium gluconate, should be readily available. And again, the risk for magnesium sulfate toxicity is the possibility of respiratory depression. Multiples, and that ends gestational hypertension. So multiple pregnancies, twins, triplets, quads, and beyond, that's considered a high-risk pregnancy as well. Our assessment is always going to be for preterm labor because that's the greatest risk. And is the mother able to carry, how close to term, to 37 weeks can we get this mom? So our assessment's going to be, is she monitoring herself for contractions? And the management of multiples may include restricting some of her activities in the 3rd trimester. So at times, it's possible that women who are carrying multiples, the treatment might be that she leaves work earlier than, let's say, her singleton counterpart. They also sometimes will consider giving mom betamethasone prophylactically in case she does deliver her babies early. Polyhydramnios and oligohydramnios, this is too much or too little amniotic fluid. And when we see that in our client, for polyhydramnios, the biggest clinical manifestation you'll see is that she'll have increased bundle height measurements and she'll have quite a girth. And for oligo, she may have decreased bundle height. Typically when we see this, one of the places that we can look is on ultrasound is to check for the kidneys to see that they appear to be normal and they're not enlarged. It also could indicate that there's a problem with the placenta or membranes, so we want to check fetal well-being. And it also could be the size of the fetus, so if the baby is macrosomic or IUGR. Typically if they have polyhydramnios, there's not a lot